At the very offset, I would like to thank the scientific committee and the organizing committee to have me here and to talk on a topic which is quite close to my heart, incremental peritoneal dialysis. So just to set things moving, I would just give you two real-life case summaries. So this was a 35-year-old lady who was on my follow-up for more than 10 years. She was a lupus nephritis, progressively landed in CKD5. She was working as a data analyst in a private firm and had a busy schedule of 5 out of 7 days working, and at least from 8:30 to around 6:30 p.m. She now presented with increasing exotemic symptoms of nausea, itching, persistently bad parameters in spite of maximal supportive management, had a decent urine output, and had a GFR currently of around 6.1 with a creatinine of around 8.1 and a body surface area of around 1.6. So just to get things rolling out, how many of you would have opted for what form of therapy for her? In my patients, I usually designate the modality once they are with me at CKD4 or early CKD5. So for me, it was not a confusion. So she was in continuum management. But what would have been your options had she presented to you for the first time? A peritoneal dialysis, hemodialysis, and obviously transplant is not on board. So these patients didn't have any live-related donors available. Okay, so let's move on to the second summary. He is a 57-year-old gentleman, a banker executive, equally busy schedule, and again in continuum now reaching end stage with uremic GI symptoms, had a similar GFR of around 6.8, no known comorbidities currently, had a angiography which was done with some plasty done 5 years back, and that's the time he started consulting us with a creatinine of around 3.5. So again, the choice of modality without transplant is what at times is left onto the patient or the doctor to decide for the patient. So what in next 15 minutes or so I would be talking about is what do we mean entirely by incremental PD? What would be the advantages and what is the evidence for prescribing incremental PD? How to start a patient on incremental PD? What are the challenges? And just to summarize how we went around with these two patients. Well, as very rightly said, incremental PD is a concept rather than a prescription. So it's a strategy. It's a strategy which we sort out with the patient and the caregivers, and as we had been discussing in the previous session, they form the core. We as physicians or as nephrologists are there to help them out. And by meaning incremental PD is any PD prescription which is less than standard dose. But the important and essential thing is that we should have an intent to increase the dose of peritoneal dialysis once it is required. And hence residual kidney function is what is of prime importance. So as the residual kidney function declines, we should increment the dosage of peritoneal dialysis. Well, how common it is? This is the data from the DOPS database, and this basically looks at single centers in various countries, Australia, Canada, Japan, and US, and we can see roughly a quarter of the patients would be doing incremental PD, and in these countries, incremental PD is doing less than 4 exchanges a day. This is the data from the Australia and New Zealand, and it shows that over the years, there has been a progressive rise in the patients who actually are taking up incremental PD at the start. In our country, unfortunately, the data is not available, but I believe quite a few of us are still doing incremental PD because for India, incremental PD would be any PD which is done less than 7 days a week, any patient who is on automated PD with a NIPD mode, that is a day dry mode, or the patient who is taking peritoneal dialysis of less than 6 liters a day. As I said, in Western countries, it's predominantly 8 liters a day. In our country, because of the low body surface area, we do tend to believe that just like in Hong Kong trial, we should be okay with 6 liters a day of PD. But as we were discussing previously, not every under PD or a substandard dose PD is incremental PD. So what is not, when we mean is incremental PD? As I said, the intent to increase the dose of PD is paramount. So if you are doing a palliative care PD, that is you don't intend to increase the dose of PD, then it is not incremental PD. If we do a urgent start PD, that is we start a patient soon after putting in a PD catheter, we start off with lower doses, but again, that is not incremental PD because that is just a tide over period. So paramount in incremental PD is to have an intent to increase if required, and palliative care low just to save the cost of dialysis, as at times we used to do, is not incremental PD. So what could be the potential advantages of incremental PD? So for that we should be knowing what is adequate PD. We all know that currently adequate PD is defined as a KTV over urea of weekly of more than 1.7 and a weekly creatinine clearance of more than 45 or 50 depending upon what guidelines you follow. But we also know that this is actually more hypothetical and it's not supported by a good randomized control trials. We know about the Edimax trial, we know about the Hong Kong trial. We even know that in Canusa, residual kidney function was more important than the peritoneal KT over V. So it's more, you can say, it's not to do, we have not done KT over V of less than 1.5 and 1. We know that a KT over V of less than 1.5 maybe has a poorer outcome. But it's definitely not clear that if we have a KTV of more than 1.7, it's good. So maybe we have the minimal dose of KT over V, but we don't have a maximal or a good dose of KT over V. So we should not be going below 1.5 or maybe 1.4 and creatinine clearance of less than 40. But is there any benefit of increasing it further? We are still unsure. So what the ISPD guidelines currently is, they focus on high quality goal directed PD, and this talks about improving quality of life, decreasing treatment burden both for the patient as well as for the caregiver, and this involves a shared decision making between the three important players for peritoneal dialysis prescription, that is the nephrologist, the patient and the caregiver. And the parameters which we look at for the high quality goal directed PD is not only the small solute clearance, we also talk about the health related quality of life, the volume status and the nutritional status. So as we move away from small solute clearance, we have to look at the patient more holistically. We have to look at the quality of life, we have to look at the nutritional status, and we also have to look at the volume status. And this is where incremental peritoneal dialysis comes in. So what advantages the incremental peritoneal dialysis brings on board? Obviously, since the patient would have to do less number of exchanges, might have to do less number of days of exchanges, his productivity is bound to increase. The burden of therapy is going to decrease. The patient would gradually build up on peritoneal dialysis, so his anxiety about the procedure might also go down. And since we know that low volumes would be associated with less mechanical symptoms and maybe better appetite and less amount of pain and heartburns. So it's likely to improve the quality of life. Obviously, it would be economical and it would have significant environmental benefits. We all have been talking about green dialysis. So it would produce less of plastic waste, it would have lesser consumption of water and lesser transports of the consumables. So this is a study which was published recently. This is from Italy. And they basically looked at the incident peritoneal dialysis patients from 2015 to 2019. I'm sorry, this is a US cohort. And they basically looked at 107 propensity matched pairs for CAPD and 722 propensity matched pairs for APD. And they looked at a 12-monthly follow-up and quality of life scores. And as we can see here, the patients on peritoneal dialysis had better parameters on almost all kidney disease quality of life scores. The effect was not very much beneficial in the patients who were on APD. But as we can see here, incremental PD, in fact, clinically had no red sign, no red flags. If at all there was slight benefit of doing incremental PD, it didn't have any effect on the 12-month technique survival and patient outcomes. This is a study from Italy, which basically looked at incremental PD and effect of the environmental burden. Just to summarize the study, one less exchange PD in a year results in added 4 months cost of peritoneal dialysis. So you can actually have 4 months extra PD if you just do one less exchange a day. You would produce around 50 kgs of less plastic waste, and obviously you would have a decreased carbon print because of less deliveries and water use. So environmental and economic benefits of incremental PD obviously are there. So it's a greener form of dialysis, and it also gives us better quality of life. What could be other potential advantages of incremental PD? It would obviously lower glucose exposure, and we all have been talking about glucose and bioincompatibility of PD fluid. So once you decrease the glucose burden, decrease the bioincompatibility of PD fluid, you would have better peritoneal membrane preservation, maybe better preservation of residual renal function, and thereby improving patient and technique survival. And since you would be doing lesser exchanges, maybe you would have lesser peritonitis and exit site infections. However, the data or the evidence for this is pretty sketchy. We just have one small single center randomized controlled trial from China. We have few single center observational studies, and more recently in last year, we have few small propensity matched cohorts from the registries, one which I already showed you from the US. So what are the important trials in incremental PD? Well, this is the only randomized control trial we had. This had around 140 patients, 70 in each group. This was done in China. And what they targeted was a KT over V of more than 1.7 or the presence of uremic symptoms. If they were unable to attain either of that, either the KT over V was less than 1.7 or the patient had quote unquote uremic symptoms, they added a fourth dwell. So all these patients by default did 3 dwell, and they added a 4th dwell if needed for small solute clearance or uremic symptoms. And what did they find? They found that there was no difference in patient anuria-free survival in the estimated GFR and urine volume. So as opposed to what was there theoretically, they had no difference in residual kidney function. Not unexpectedly, the patient had a lower KT over V, but still a reasonable KT over V, and they had a lesser ultrafiltration, but none of the patients on incremental PD had volume overload. If at all, the patients on incremental PD had longer peritonitis-free survival times and fewer peritonitis episodes. So if we go by this randomized controlled trial, the patients on incremental PD had lower peritonitis rates, but no benefit on residual kidney function. And we all know that 70 patients in each group is too small a trial over a follow-up of 24 months. This is a study from my dear friend Tarun from Pune, and he basically did a very bold study in his period of time. He actually started this study way back in 2006, in which he prescribed patients ICO alone versus standard PD, which was 3 exchanges a day, and he reports a 5-year outcome in his single center study. So what he did was, any patient with a urinary KT over V of more than 1 was offered an incremental PD. That was only 1 ICO exchange a day in the night versus a standard PD. He had around 40 patients, 13 and 28, and he assessed the adequacy at 1, 3 and subsequent 6 monthly interval, and he shifted to conventional PD if the patient met low adequacy targets or if it was clinically indicated. The patients remained on ICO alone for around 9.6 months, had a lower peritonitis rates, and the patient survival were much better. But again, single center study, non-randomized, the patients in ICO group actually had higher residual renal function, had a urine output of more than around 500 mils per day at this time of initiation of the PD. So within the limitations, it's still a very important study. And coming to the more recent cohorts, this is a multi-center registry analysis of incremental PD, and this is from Australia and New Zealand data. And this looked at 10-year follow-up of the 10-year follow-up patients from 2007 to 2017. They defined incremental PD as those receiving less than 42 liters of PD fluid per week. And what they found was that incremental PD was associated with reduced peritonitis rates and lower incidence of 30-day transfer to hemodialysis. So slightly better survival on technique survival, and as we can see from this graph, lower peritonitis rates. The outcomes as far as the patient survival remained the same. This is a study which again from Australia, which looked at incremental PD and whether it was feasible in patients with residual renal function. It was a retrospective single center cohort, again propensity matched group, and they found there was no difference in PD technique survival or rates of peritonitis or hospitalization. However, the patients on PD had higher peritonitis-free survival rates. So again, patients on incremental PD had lower infections complications as compared to patients on patients on standard PD. Well, this is the secondary analysis of a very important randomized controlled trial which we had, was the balance trial from Australia and New Zealand, which basically looked at the physiological fluid versus standard fluid. But in the standard analysis, in the secondary analysis, what they found was the small number of patients who were prescribed incremental PD, that was around 45, as compared to full dose PD, that was around 105, they found no change in the primary outcome of residual kidney function and in the secondary outcome of change in urine output. And there also was no difference in the slopes of the decline of both the urine output as well as the residual kidney function. So negative study, but again it was a secondary analysis. But what it showed very brilliantly was that the patients on incremental PD had a much lesser glucose exposure as to patients who were not on incremental PD. So maybe the benefits of incremental PD might be more visible after a longer period of follow-up, because you would have lesser changes in the peritoneal membrane and lesser conversion to higher or a faster solute clearance. I think so this would be the final study from Korea, which again was a single center observational study. These had a decent number of patients, and that's why I've quoted this study, around 170 patients. And again, it showed a similar patient technique survival and a peritonitis-free survival, but had a lower risk of anuria. So again, a bit beneficial in residual kidney function, but as I said, the data or the evidence is very scratchy. It's not a very convincing data if we go for incremental PD. So how to start a patient on incremental peritoneal dialysis, if at all we want to start? Firstly, how many patients can actually, who follow you up for the initiation of PD, would be feasible to start incremental PD on? Well, if we go by this US data, US-Canada data, around 50% of the patients at any given time in a PD program would be feasible to start on incremental peritoneal dialysis. So this is a possible modality in a good majority of patients. Another physiological study has very brilliantly demonstrated that even if you have any GFR of more than 6 ml per minute, whatever be your membrane characteristic, whether you are a slow transporter or whether you are a fast transporter, 2 dwells per day can achieve significant or the sufficient clearance goals if you have a residual renal function of more than 6 mils per minute. So again, we are not talking about ideal study where we started dialysis at the GFR of 10. I am talking about more conventional start of dialysis, that is a GFR of more than 6. So it's not that incremental PD is only there if we start early. Even if the patient is started on conventional indications of dialysis, still 50% of the patients, it would be feasible to start incremental PD. What we have to realize, as we were discussing in the previous session, is this is a patient-centered approach, and our target is to keep the patient well, functional, and for the longer time on peritoneal dialysis. And targets other than small solute clearance are more important. So what is the ISPD guidelines? This is what aligns to the ISPD guidelines more closely, is that we have to look at the quality of life, the volume status, and the nutritional status of the patient, rather than only looking at the small solute clearances. So how to prescribe? As I said, any PD prescription using less than 6 liters per day or night alone intermittent PD is incremental PD. Tarun started with ICO alone. I also have few patients on ICO alone. It's a very good modality. NIPD is probably the commonest form of incremental PD which I prefer. It's expensive. You can choose your own incremental PD. As I said, it's a strategy, it's not a prescription. So while prescribing incremental PD, it's essentially a counterbalance between the dwell volume, the number of exchanges which minimal you have to give, and the number of free days which you can afford to the patient. And this would depend entirely upon the patient factors like the lifestyle, the residual kidney function, the membrane type, and the body size. So if we have the counterbalance between these two aspects, we can give a good incremental PD prescription. The only challenge which the PD prescription in incremental face is a good follow-up. So you should follow up the patients at least quarterly. That's what I do. They should be doing clinically well, which is probably the most important thing while I see on the follow-up. They should be euvolemic. They should always come monthly chart of the residual kidney function at least on one day. We should closely ask for uremic symptoms. We should look at the parameters other than urea and creatinine, and that would include calcium, phosphorus, bicarbonate. We should be assessing their nutritional status, the health-related quality of life, and maybe lastly looking at the small solute clearances. That I would do 6 monthly or even a yearly. So what are the challenges? Essential challenges, as I said, are predominantly greater workload to the nephrologist and the unit, PD unit as such. What we have started using, at least the COVID taught us the same, is to start using telemedicine for the patients who reside remotely. It is possible. You just have to connect them with a video call, and you can ask most of the questions which you would be asking sitting in the clinic. And though it's not a substitute, but it's still a viable alternative if the patient can't come all the way to your unit. The most important problem which I face in practical terms is the patient inertia. So once the patient gets used to incremental PD, he would be quite resistant to increase the dose of PD. And this is what you have to teach them every time he comes to you. Every time he comes to you, you say, so far so good. You always say, so far so good. So that once you say, now you have to increase your PD, he would be more receptive to your advice. If you say, very good, very good, very good every time, and suddenly one day you said, okay, now you have to add your day dwell in your NIPD, he would be resistant to that. So it's always important to treat the patient psychologically as well, and to break the news in bits rather than all of a sudden. So my usual story is always, so far so good, so far so good. It's important to realize that residual kidney function is of primary importance in achieving both the small solute as well as the middle solute clearances. We all know for the middle molecule clearance, you require the duration of PD, which is more important. And since we are cutting down on the duration of PD, especially in NIPD, the middle molecule clearance is bound to be lower. Therefore, you have to realize the primacy of residual kidney function, and you have to follow the urine output very religiously. So what we did with our patients? Well, the first patient you realize was a young female worker with as a data analyst in a private firm, had a decent urine output. We started peritoneal dialysis in an intermittent way 2 years back on her. At the start, she was a high average transporter. The initial prescription which I did was 2 liters ICO alone for 10 hours, and 2 liters of 1.5% 2 exchanges and 1 exchange of ICO on the day she was off from the office, that is on the weekends. So she used to do 3 exchanges in the weekends and just 1 exchange in the night while she was working. She was absolutely free of doing any exchanges in her office. The KP over creatinine was 25 liters a week once we started, and from the peritoneal cavity we got a clearances of 1.5. The creatinine clearance was 60 from the kidney and 60 from the kidney, and I'm sorry for the problem here, and she had the clearances of creatinine of around 40 from the urine. She continues to do well, has no symptoms. Her current output has dropped to 500 ml per day, but she still has acceptable clearances, both the KT over V urea as well as the creatinine clearances. So we are not doing any further, we are not going any further on her, and she continues on IPD. The second case also had a similar start. He had a decent volumes, he had a decent exchanges. He started on a NIPD of 10 liters a day with 5 exchanges, did all 7 days, was day free. He required a cart for his anginal symptoms and had a progressive decline in urine output 15 months back, and that's the time we started an ICO day exchange for him because he was not maintaining his volume. So now he is on NIPD with a day exchange of ICO, which is a conventional peritoneal dialysis, but he did pretty well for around 10 months on incremental PD. So he gained 10 months on incremental PD before finally going on to a full dose PD. So in the end, ladies and gentlemen, what I've tried to highlight is that incremental PD actually aligns closest to the current ISPD guidelines of prescribing high quality patient-centric goal-directed therapy. It should be the way we should move forward rather than being dogmatic of starting everyone with any amount of residual kidney function the same form of dialysis. So peritoneal dialysis is not one size fits all. We should tailor the prescription of peritoneal dialysis according to the patient needs and the residual kidney function. Unfortunately, though I have prescribed very passionately, talked very passionately about incremental PD, I have very little evidence or data to say that it's better. But whatever is available, I can safely say that it does not do any harm. So whenever we do a non-inferiority trial, it's always a non-inferiority trial. This is not worse than a conventional PD, and I can safely say this much with the evidence we have from a small randomized control trial, from various registry data, from various propensity matched control cohort studies, that it is not worse than conventional PD. It's at least as bad as conventional PD. Gives us significant economic and environmental advantage, provides better quality of care, might preserve kidney function better, might have reduced chances of infective episodes. And it's a viable modality for majority of our patients once they start peritoneal dialysis. And you can have a median of 12 to 18 months easily on incremental PD before they move on to a conventional full dose PD. The only challenge remains two. That is closer supervision. That's the thing which you have to do very passionately, and continuous counseling so that the patient does not push back once you say that you have to move on to a more conventional PD. Thank you.